Many clinicians come to EMDR seeing it as a tool to add to their practice rather than as a lens through which they might focus their approach to their work. Can you a little bit discuss EMDR as an orientation rather than simply a technique?
There's several facets to that, but it's a really good point, Steve, and I'm glad you bring that up because a lot of people do think of EMDR as a simple technique. They think of it as just, you just think of a disturbing memory and you do this technique and that's all there is, and the rest of the time you're doing regular therapy. But actually, EMDR is not a simple technique, it is an approach. And what makes it an approach is the adaptive information processing model, a way of conceptualizing the difficulties that people have, and a way of developing a treatment plan. Without the AAP model, EMDR would be just a simple technique, and it wouldn't give you an overarching framework for how to think about cases. I'm actually an EMDR therapist even when we're not doing reprocessing. I'm thinking in the AIP model all the time. And the adaptive information processing model is rooted in earlier information processing models that go back to the 70s, but it approaches the idea of emotional information processing differently than other models of therapy. Imaginal exposure also sometimes talk about the need to do cognitive processing because of the limitations of pure exposure therapy. But they don't understand emotional information processing the way we do in the EMDR world through the lens of the adaptive information processing model. The AP model gives us a way of thinking about how memory is organized. It gives us a way of understanding how people emit maladaptive behaviors. It isn't that people are bad. It isn't that people want to do bad things. People process reality. They process their experience through the lens of what's stored in their brain, and it's stored in maladaptive ways, and the way they're going to perceive the world is going to be maladaptive. If you see someone smile at you, you might think that's a friendly person. Someone else looks at that smile and thinks, what are they trying to get out of me? How are they trying to manipulate me? Okay, that's suspiciousness, the paranoia, the responding to cues, innocuous cues in the environment, as if they're a trauma that's about to happen, like with combat veterans who hear a loud noise and then think that they're under attack. This is what's stored in the brain, and understanding the way that dysfunctionally stored material is organized in the brain is informed by the AIP model. And so we need the model to be able to conceptualize what's happening with our clients and how to develop treatment plans. With the simplest cases of a single incident trauma, you don't need a very complicated plan. But those kinds of cases are relatively rare. Most of the cases that we see are either complex trauma cases or they're cases with co-occurring disorders. And with co-occurring disorders, the way you're going to organize the treatment plan, the sequence of targets that you're going to work with, needs to be carefully selected to meet the needs of that person. Without the AAP model, I don't know how people would be able to figure that out. You need to understand the model. And so in the beginning, when clinicians are first trained in EMDR, they often don't understand the importance of the model, and they are approaching EMDR as just a technique. But when they start having some successes and some treatment failures, then they come back for more consultation, and they begin to appreciate more and more the need to think within the model in order to be successful with a wider range of their clients.